we know very well what is the risk factor, but someone, especially vascular surgeon, don't remind that pelvic reflux has been identified as an important contributing factor to varicose vein recurrence. And this slide that was shown before, it's very important because the definition of tactical error means inappropriate intervention, means that you haven't made a good mapping. Technical error, persistent reflux because inadequate intervent. And then this other part, that means that to be defined needs the duplex. And this is something that is not every time clear. In fact, simply ablating or stripping saphenous vein and not treating a refluxing accessory saphenous vein will lead to early recurrence. It's clear. And so the duplex mapping must be done before. Here, probably everyone make this, but probably in the community is not so sense. Neurovascularization and recanalization, it's two different situations. Neurovascularization occurs when the vein wall has been transected and probably means that is more frequent when you ligate the saphenous vein. Recanalization occurs when the vein wall has been affected on its luminal aspect and probably is more common after the endovenous ablation. And this systematic review that I reported testimony this thing. But as you see here, controlled trial show that after 5 years, clinical visible recurrence originating from the saphenous venous junction region after endovenous laser were observed in 33% compared with 17%. And so, what is the truth? The canalized saphenous vein after terminal, chemical, and so on must be treated. The first step is to determine if treatment is necessary, as shown very well the doctor, Pai. A widely patent vein that accepts a catheter can be treated with normal methods, probably. If doesn't accept a catheter, we have the chemical ablation. And finally, ligation from the highest refluxing point, such as saphenous venous junction, or perforated, with or without stripping. And so surgery appears. To reduce the incidence of neurovascularization in some randomized clinical trial, it's proved that oversewing the junction stump to close the endothelial funnel to avoid contact with the surrounding substances. Other studies report a good result of implantation of prosthetic patch. But the Dutch guideline defined that duplex ultrasound is strongly recommended for pre and perioperative, again, and say that redo groin and popliteal fossa surgery have a higher risk complication. And there is no compelling evidence that barrier technique in reduced surgery prevents development. And so, what is the truth?